Thanks, Alan. I was just trying to recall in my entire life when I've been mentioned in the context of being called lucky to have you here. Twice, I guess I'm naturally suspicious, and when the first time it's announced that it's lucky to have you here, it's by a GP, and the second time it's by a senior civil servant, then I'm even more suspicious. But anyway, it's great to be here and great to have the opportunity to come and talk to you in something of a slightly random sense, just offering a fairly loose chief officer perspective about this relatively new world and new role that we are trying to work our way through and understand. Going back the wrong way, sorry. The context of this is really important because, as you'll see later in the slides, I'm going to talk a bit more just about some of the uncertainties that we're all encountering. And in 2015, in my career since 1990 in the NHS, probably maybe the second single biggest set of changes started to emerge that were impacting on us organizationally, structurally, professionally, and in the roles that we do. And in 1990, all that those kind of working for change, patient GP fund holding and types of reforms came in. And I just came into the NHS when all of that was happening. And 2015 probably is as big as that in terms of some of the things that we're encountering. I don't intend to go through all these bullet points, but you'll be familiar with many of them from a different perspective. The major change that was announced, the GP contract. At that point, you had HSCPs either in shadow form or the early stage of their new legal status. There was a whole new narrative that was starting to emerge that we didn't really understand, as Greg was referencing earlier, about quality and delivery of outcomes. We'd heard of these words, but actually fleshing them out and putting them into the context of these new organizational arrangements was something that we still needed to do. The narrative that came out about the sense of multidisciplinary leadership within this kind of context of integration, cluster working, the emerging roles of these CQLs, a whole new set of kind of shorthanded narrative was starting to define what was going on. So certainly there was lots at that time, and still that was feeling to us to be new, challenging. And in that context of the new legal entity, where many of us who've got a leading role in that is still trying to understand what that means on the ground, both for ourselves as individuals, as professionals, in terms of ways of working, as well as what the legal status is about how services work, about how money flows, what the governance is. So what did we do in Renfrewshire? And this is just a quick summary of some of the things that we started. What we started to do was just to build a basic dialogue. Richard talked about the conversations on a Friday afternoon. I probably irritated or noised up too many people about some of these things, but just trying to get a message across that this was not about writing big, long, lengthy documents. It wasn't about giving us tons and tons of guidance. It was operating very much with a sense of kind of slow progress and emergence. What we did, we started a dialogue with GPs in our GP forum. We started to build a dialogue with the individual 29 GP practices that we have in our HSCP area. We had what we referenced as an initial set of clusters that were just happened to be the practices around which we were designing or providing our district nursing service. And on the back of that first round of conversations, we then took a brave step of moving into something called cluster development seminars, where in these 10 initial clusters, we started to build a dialogue. And that dialogue, when I look back, and perhaps some of these nomenclatures, some of these titles have been added with the benefit of hindsight, but it was very, very much a simple improvement-based conversation. It wasn't anything especially clever. It certainly wasn't at the kind of NASA end of improvement science. Just saying, well, what do you think? What works well? What works less well? Why do you say that? How do we know it's not working well? How do we know it's working well? What should change and why, and what can we do next? And that led to some really dead simple, practical next step actions. When we used a very simple methodology, a 30, 60, 90-day kind of plan, working with practices, but it was really simple stuff. I don't particularly enjoy these phrases, but a phrase like low-hanging fruit springs to mind. It was practices simply wanting to have better connection between the services that we manage and provide and the services that they provide. How can we get a single point of contact with our district nursing team? How can we get a single point of contact with health visiting? How can we find out which of our patients are part of your mental health service or your addiction service? But very much at that point, it was around trying to build trust, build understanding and engagement. If I've learned nothing else in working with some of the people as I look around the room for 20-odd years, I think it is about learning when you're working in the arena of GPs in general practice. It's important to build slowly that sense of trust, that sense of credibility, that sense of shared understanding, and that sense of meaningful engagement. Because as Alan said, I can't think myself of a better group of professionals to give us that kind of advice about what's working, what's not working, and what needs to change and why and how. So it was very much about just trying to show that commitment, to try and understand and shape roles, to build that understanding, and also give some sense of direction. Because this is what it was taking us to. This, as we start to see the PQLs come into place and then some of the CQLs, this is my perspective about how people are feeling, and it's not just made up. It's an emergent sort of feel from the conversations that I've had, but it's also, to be absolutely frank, this is what I was feeling as I stepped into the role of being a chief officer. I'd never been a chief officer managing social care services before. I got a career of 26 years, 27 years working in the health service. And it's okay to feel some of these things. I think it's okay to offer a perception that CQLs are pretty unsure about things. It feels a bit scary. Probably you've got a sense that everybody else seems to know what they're doing. Believe me, we don't. You're not sure where to start. How do you engage with other GPs? Even though you might be working in one building in the same health centre, there's not a strong track record of practice working collaboratively, just having straightforward conversations. What's an HSCP again? It's a question I often ask early in the morning as I'm out walking the dogs, but it's often a question that we get asked. What are you? What do you do? What are you responsible for? And some of that is not as straightforward as you would think. People ask the questions, when will I get to understand this and know what the answers are? You won't, and you never will. What will my peers and others think about me? That is something that I think all of us think, because if you're not sure about some of these other things, and particularly GPs, you are really concerned about becoming one of them, whatever that is. You certainly don't want to be ever deemed to be part of management, that's for sure. So remember some things from my perspective, and I believe most other chief officers probably share this similar perspective, although they will have an appetite to get some answers quicker. Clusters are not here to fix everything. They're not the new panacea. They're not the new silver bullet. They're not here to fix all the ills of general practice, the austerity, the lack of clarity about some of the questions that we have day to day, and fix the workload. The roles, the entities, the clusters, the PQLs, the CQLs, these are all new things. And broadly, my experience tells me these organizational changes take about as long as they take to unravel, to settle in. And I think I'm now on my 8th or 9th major structural change in 26, 27 years in the NHS. So they change pretty fundamentally after about 3 years, given government policy. But I think it will take 3-5 years for some of this stuff to settle in and people to become confident in their roles. Remember, we're still finding our way. HSCPs are still finding their way in terms of what they do, how they do it, how they balance the books, their governance. And remember, when you stop and think, the old issues are still the new issues. Things haven't fundamentally changed in the arena in which you operate. Prescribing, interface with acute, shifting the balance of care, improving access, better information, getting better value from our resources. So here's just some thoughts about what you should be thinking about here and now. And it's very much on a journey of kind of emergence. And sometimes that emergence will happen sooner, sometimes a little bit later. My advice to CQLs is just get up and start building and working at sustaining those relationships with your PQL colleagues in the cluster. Start to build an understanding of what the issues are in your cluster. What are the areas for improvement? But not just in the practices and in the cluster, but also across the HSCP and beyond. Taking what Gregor was saying earlier, and I've read that report a couple of times, and Gregor knows I think it's a bit too long, but it does essentially take you down the path of having a broader view of quality, not a narrow view of quality. A challenge to CQLs, and I don't mean this in a patronizing way, but be curious. It's okay to ask questions. It's okay to dig a bit deep. It's okay to ask that kind of daft lad question, which is, I don't understand this, so please help me to understand it a bit more. Share and talk about things. And again, we often think it's dead straightforward, but it actually takes quite a big effort to get up and go and talk to other people, other GPs in your patch, and actually explore some of those issues. Think about how you can work together with CQLs. We've got our first CQL network meeting next Monday, or a week on Monday. And it is about a journey of learning from each other and sharing what we're doing. Work hard at being more connected That's like another obvious thing to say, but it's really difficult. Some of the CDs in the room will know that it's taken them a long time to build that sense of network, of alliance, of just getting along and talking to people and just having some of those conversations about where things are at. Certainly start small, but think big. I don't see the role of CQLs and this role of quality improvement being about only fixing tiny things at the smallest practice level. Because if we want to deal with some of these bigger issues, we need to do them at scale. And scale can be whatever it means to you. This is very much about strengthening GP leadership, and my time working with Alan and people like John Ip and others through the LMC, it is about trying to build that momentum to get a clearer, a louder, and more effective voice from GPs about GP leadership. And that we've struggled with that. We have struggled with that. And we often get deafened by the booming voice of acute services and other things like that. In terms of the cluster quality improvement programs, keep them simple, make them connect, and develop them. Don't try and do anything too fancy, too soon, too quickly. What about the next 12 or 36 months? Well, build confident CQLs. Be prepared to be confident. That might sound like an obvious challenge, but being confident in the role is an important challenge for yourselves. Build those influence links. As Alan referenced earlier about GP subcommittees, think about where we can start to get representation and connection with advisory bodies. Put your foot in the door of the HSCP, senior management teams, clinical care governance forums. Use the clusters to build connections and interfaces that improve service pathways. Don't believe that because we look like we know what we're doing, that we know what we're doing. Bring that sense of challenge. Use the clusters for tests of change, piloting ideas, connecting to the wider HSCP, but don't do it in isolation. Do it as part of that sense of connection. Use the clusters to provide better practice advice and support between practices. Now, this is something that I know I've said they're not going to be a fix for everything, but those last 2 points are really important. I would hope that clusters start to open the door of dialogue between practices, between GPs and practices, about how we can work together. Now, I'm not saying this is my fix. I'm not saying this is my strategy, but I think if people start to talk more, they start to talk about more things. And if you start to talk about more things, who knows where that might go to. But I would imagine the old issues are the new issues. It's about sharing, doing more together, leaning on each other, buddying up, sharing ideas, sharing resources even. So in summary, what would my chief officer perspective tell you? Be curious. Be brave and build a dialogue, build relationships, build networks, and build alliances. Try things. It's okay if they don't work, but try things. Be comfortable with not being sure, because 2 years into being a chief officer, it's a feature of how you feel probably most days. Understand the environment you're in. It's really important. GPs generally don't spend a lot of time trying to understand the environment that they sit within in a bigger sense. They understand the general practice environment, not the wider environment. So to get things done and be effective, you do need to understand how things get done currently, and then you can understand how you want to fit with that or challenge that. Focus on quality and improvement, and quality improvement. The two things don't always sit together. Work hard at becoming confident. Build your own confidence. Build that by understanding that others are unsure. Learn from others. Build that sense of understanding and connection in the system. This is a tricky one. Be open to the change and the possibility of difference. It's a bit of a kind of a quirky management line, but being in a space that feels uncomfortable is actually probably where a lot of change starts, because you ask questions, because you're curious. But most times we spend a lot of that time in that space, and GPs just now probably are feeling quite like that because the contract's changing, the world is changing. And the last point for me would be to say stick at it. We've struggled to get CQLs to step into the role, and then when they step into the role, they only want to do it for an initial period. And I understand that. But I do hope that CQLs generally stick with it, because learning from the last 10 years about how clinical directors, GPs have stepped into those roles, become confident in those roles, become a real voice for primary care and general practice in those roles, sticking with it is a really important point. It's new, it's emergent, so your stickability is going to be really important. And then let's hope it doesn't all change again. Thank you.